we're going to hear from the next speaker, Laura Valentini, who's going to talk about indications and results of detethering, monitoring, intraoperative monitoring, and results of detethering. First of all, I have realized that we're all focusing on each of us is focusing on different patients. My patients are not patients with occult tethering, but patients with simultaneously both malformations, and they're all children. So there are different case series to those of Miliori and those in the literature. We have focused on cord tethering because we've dealt with cord tethering for many years. Dr. Soiro started off many years ago, so we have dealt with this for years. And we're kind of torn between two situations. That is, detethering of so-called occult tethered cord with a conus that's in a normal position with all the ensuing ducts, with all the relating doubts, and doubts as to whether to perform surgery on a patient who has apparent tethered cord but no symptoms. These patients too for example, children undergo MRI studies earlier, so they have no symptoms because they haven't had time to develop them. Based on the symptomatic patients that we have performed surgery on, we have been able to work out the preclinical picture of these asymptomatic patients. Familiar incidence is quite low. This malformation does run in families, but it doesn't seem to be countered by the administration of folic acid. We're talking about an occult disorder, but occult is not a correct word because these patients, in fact, have skin lesions or signs, and this should lead to suspicion as to this malformation. Most children and also adults had skin signs in 70% of cases. The symptoms due to tethering, as we all know very well, are related to the lack of ascent of the conus, which is supposed to occur at the 3rd month of gestation. And the mechanism that explains this pathology is conus ischemia. This is why many symptoms that appear at the conus do not decrease. The worsening is documented very well by urodynamic studies because it's difficult to evaluate sphincteric function in young babies. This is a natural history chart, and it's difficult to find tethered cord that's asymptomatic above 12 years. But this is the old picture, because evaluating sphincter function in babies is difficult, and therefore it becomes obvious only when a child becomes 3 or 4 and can't acquire sphincter control as he should. In older children, diagnosis is reached as related to motor symptoms. In adults, motor disorders are prevailing, but adult patients are much more deteriorated than younger patients. The diagnosis is made based on MRI imaging studies, which now have allowed us to identify many patients who are still asymptomatic. Since it is difficult to evaluate sphincter function in the first 3 years of life, we have heavily resorted to urodynamic studies. As early as in the first year of life, according to some studies, urodynamic function can be altered. Together with Giorgio Selvaggio, I have realized that when monitoring at 6-month intervals, sometimes we detect alterations in bladder function. So this is the protocol we use to diagnose young children. Holocord MRI of the whole neuraxis is one of the tests. This case series was given a neurological evaluation based on this scale. Score 2 coincides with sphincter malfunctioning. From diagnosis to surgery in this case series, nearly 5 years elapsed. There was a lot of wait and see, and we were in doubt as to whether to operate on these patients. And patients tended to shift to the right and become more and more symptomatic. This was much more apparent in adult patients. Adult patients had much more impaired neurological findings. At a post-op level, however, there was no variation except for a slight worsening at the immediate post-op time, which usually was resolved on a long term. At the time of diagnosis, patients had motor symptoms and no sphincter component. In the period to diagnosis, the neurological picture got worse. After surgery, there was a slight worsening, which varied to a great extent, with often an improvement in motor signs, and then on a long term, there was an improvement. With long-term follow-up, retethering sometimes caused relapse. This is our case series, and this is a picture showing our surgical technique, which is quite well known. I'd just like to note a currently debated topic, that is, to what extent lipomas should be removed so as to prevent detethering, because it seems that if not enough of them is removed, retethering occurs. There was a conference in South Africa, and there was a great debate between the South African doctor and an American doctor as to whether to operate on these patients. The American school of thought has always been aggressive and suggests removing as much as possible of a conus lipoma, whereas the South African school says that as little as possible of the lipoma should be removed when patients are asymptomatic. We, however, think that it's important to perform intraoperative monitoring. Each patient is different, and since we're faced with a malformation and the events that lead to the malformations are different, there are no two identical lipomas, and therefore it's important to control both perineal plane functionality and the muscles of lower limbs, especially if we operate on asymptomatic patients. This is one patient who was detethered, a fatty lipomatous filum was sectioned, and this is a placoat that was closed with proline sutures in order to allow for shifting of the conus when the child grew up. Duroplasty used to be performed. Now there are doubts as to whether it's effective at preventing retethering. Something we'll perform is laminoplasty because it allows for a better healing of the bone side and prevents long-term deformities. Monitoring is always required. This is one patient who was given a plain detethering technique. So this is how we did it. This is an older girl. She had a severe low-lying tethered cord. She had night neuritis, and she was psychologically treated for a long time. Then her problem became apparent because she had renal failure, because these patients develop lateral dyssynergy, and therefore their bladder dilates hugely. And this dilation, this bladder dilation, causes the bladder to no longer recover its functionality even after the problem has been removed, because the muscles are much too stretched. These are the two stumps after the resection, the two pieces, the two ends, and this is the procedure for closing the dura. As for retethering, on X-ray, not always do X-ray pictures give good results, so prone MRI has been chosen. Results of surgery are related to the complexity of the picture. With plain detethering, we do not expect complications, whereas with lipomas involving the whole of the conus, we expect neurological deficits, especially when we are faced with relapses, and doing surgery on these scarred tissues is very risky and involves serious complications. These are the types of lipomas that we operate on, and this is a plain detethering technique. And this is the stump of film that ascended well. This is cervical tethering case. One important issue is so-called terminal syringomyelia. Back in the past, it was not ascribed any clinical significance, whereas recently it was ascertained that it can also evolve, and it seems to correlate not so much to a CSF flow at the cranial-cervical junction, but rather at a cord tethering site. So the problem is treating tethering. If the syrinx is quite apparent, as in this case, we try to figure out whether it's worth cutting the conus before we cut the cyst. In these cases, we undertake FLAIR imaging studies. But remember that intervening at this site can be dangerous. Malformative tumors are often associated with this disease. This was a young patient who had urinary infections for many years, and when he came to our observation, he was already severely impaired, not only in terms of his sphincter function, this is a huge tumor as you see, but also with another problem. After detethering, because his phylum was obviously tethered, in addition to his having this malformative tumor, we realized that his epidermoid had already disseminated into the cord, the canal, as all of his roots already had these scales that were already there before the tumor was removed. Scoliosis can be frequently associated not only to chiari malformation patients but also with tethered patients, both because of traction or stretching and because children have multiple malformations. Some patients have many malformations. This is one patient with several hemispondyles. Here we performed a low detethering procedure. Here you see that the terminal stump that was opened did not decrease, even though the patient who was a female improved. What's important is that this scoliosis, which also included vertebral deformity, improved and did not require any further treatment. Even though the tonsils were low, we didn't find any chiari malformation. So after seeing these occult spina bifidus, we wondered how many of these patients had chiari malformation. And even though the conus was positioned in a very low place, patients with chiari were very few. If you will rule out the 6 cases that we saw earlier who were diagnosed with chiari malformation, those who came to our observation because of tethering had a mild descent of tonsils in 2 cases, and they were asymptomatic. This was a young girl whose conus was very low-lying. It was basically located at the canal. This is S1. And during surgery, there was a double tethering. The lipoma was tethered and infiltrated subcutaneous tissues, and there was a second tethering site through a tight filum. When I partially removed the lipoma and then dissected the filum, it was so tight that the conus quickly ascended above the dural opening, much higher up than here, as you can see in the post-op picture. In spite of this, her MR, even before that, showed that tonsils were in a normal position, which means that there was a very strong traction at the conus. This is another patient in whom we tried to perform a more radical removal in order to prevent retethering, which is a very serious surgical problem. The few patients we had to redo had a truly unfavorable outcome. This was the lipoma that was removed, and this was the conus that was at L4 and went up to L2 1 year after surgery. Let us now come to tethered cord patients who were found to have Chiari malformation, or rather Chiari malformation patients who were found to have tethered cord. Let us leave the two occult tethered cord patients alone, since they were kind of misdiagnosed. Let us look at the apparent tethered cord patients. There were 6 of them. As you can see, their cord was very tight, but their tonsils were also quite apparently and obviously descended. This is the patient that Dr. Solero decompressed twice during the same surgery section. It was a male patient with patient disorders, and he had a good outcome. This is a young girl whom we decompressed at the posterior fossa. Her immediate post-op course was rather satisfactory because she had headaches and apneas, and that improved. But later on, her syringomyelia, her dorsal syringomyelia, worsened, and she showed altered septs. So we dissected her terminal filum, and her filum ascended quite abruptly, but not so much. So this was the second patient. From the spinal viewpoint, urodynamic alterations were solved, but her syringe was stable and did not significantly improve. This was a case of adhesive arachnoiditis. I opened here and I saw that all nerve roots were fastened together, bundled together. This was a little girl with scoliosis and blocked posterior CSF flow. And this was the picture. When I opened the dura, I saw that all the fibers were bundled together in the middle, perhaps due to some infection. And this little girl, we really do not know what to do, because she's certainly tethered at a very low point, and we can't detether her, and we're wondering whether we should decompress her. This is a 12-year-old girl. She had a picture of Chiari malformation with lower limb disorders and deformed feet. Her schisis was obvious here and apparent. After surgery, she sharply improves, and so far she hasn't shown any signs of Chiari malformation. This is a little girl who had a disc hernia, tethered cord, and Chiari malformation. She was detethered, and her disc hernia was also operated on simultaneously. But after a while, her tonsils are unchanged, and CSF flow at the posterior fossa hasn't improved. Her cervical syringomyelia is still stable, but hasn't improved. This patient is asymptomatic. Her syrinx is asymptomatic. She mainly had lower limb disorders, but we're in doubt as to what to do with her. Finally, this is a patient with lower limb tethering. Her tethered cord was very low, and now she is developing a syrinx, so we believe that we will have to decompress her posterior fossa. This is a slide that summarizes all these patients. Unfortunately, it's a very small case series, but there hasn't been any variation in flow studies in these cases, and the position of cerebellar tonsils hasn't changed in these patients after detethering. So I can only say that these patients are so unfortunate as to have both malformations. Now I'd like to talk about patients with many malformations, such as anorectal malformations. They can often have tethered cord syndrome, and it's difficult to figure out with these patients how they can be kept under control from the urodynamic viewpoint, because their urodynamics have been compromised during their first surgery. But they need to be carefully monitored because of their urodynamic problem, and as soon as problems occur. This little boy had caphocephaly, a tethered cord, and he was operated on for anorectal malformation. This is when he was operated on for his caphocephaly, following which his skull grew rapidly. If we hadn't intervened this way, he would probably have developed craniostenosis, anorectal malformation, and also Chiari, but he didn't develop Chiari because of that, even though he developed clear tethering cord signs, which then improved. So, what are my conclusions? Natural history says that there are three peaks in terms of worsening and deteriorating. There was a motor deterioration during childhood, urodynamic worsening in adolescence, and pain during adult age. Post-operative deterioration is rare, so surgery can be indicated in all patients who are at low surgical risk. More specifically, surgery benefits these patients only when it comes to recent onset motor disorders and symptoms and initial sphincteric disorders. We have seen that if they're monitored over time, urodynamic findings, especially with tethered cord syndrome, can return to normal, whereas there's no effect on vesical function that was previously compromised and on adult patients. So we recommend prophylactic surgery for terminal film lipomas to prevent acute sphincteric worsening, which can also occur in case of trauma or heavy remarkable growth. As for conus lipomas, I think that these patients should be monitored urodynamically, and as soon as urodynamic dysfunction appears, surgery should be performed. Since the anatomical picture is complicated, intraoperative monitoring is required in these patients. It's still to be defined what should be done on asymptomatic patients. So far we have developed criteria for tight urodynamic tests. Urologists are not very happy, but we think it's quite right that they should be kept under control. And we're in doubt as to redo surgeries because redo surgeries on retethering have always had a negative outcome. So we believe that detethering should be performed successfully at the first shot. Thank you.